I am Dr. Yulin Hswen, Associate Editor of JAMA and JAMA Plus AI, and you are listening to JAMA Plus AI Conversations. Today, I'm joined by Dr. Nigam Shah, Professor of Medicine and Chief Data Scientist at Stanford Health. Welcome.
Thank you for having me here.
I want to just talk about your experiences and the work that you've been working on. Can you talk to me about what you think a typical day looks like for a clinician trying to piece together a patient's history and going through how they diagnose the patient and the whole system that they have to go through in order to do so?
hmm As you know, and our speakers know, there's hundreds of medical specialties. Just on our Stanford campus, we have 123 residency and fellowship programs. And the information needs of each specialty are slightly different. And if you imagine, we have this thing which we call electronic health record systems. And at some level, I mean, we're basically going dumpster diving into it because everybody puts in information from all the specialties, nursing, billing, everybody puts stuff in. And then we have to literally fish out or scavenge what we need. Something about my blood work might be buried 3 years in the past. Something about a oncology history might be buried 4 years in the past. A colonoscopy might be 8 years in the past. And ultimately is an information retrieval, but pertinent information retrieval problem, which we currently solve by literally pecking around with a mouse and clicks.
So it's literally like it's an excavation process, but the problem is everything is like a treasure. Like everything is important at the same time, right? It's not as though you're not digging through garbage. All of the information is important, right?
And important as in different contexts. I'll just use my own example, pretty genetic situation of having a slightly elevated cholesterol, getting started with a statin, getting some GI side effects. And the GI specialist and the cardiologist like don't really communicate. I mean, they write stuff down in the same document, but then it's up to the patient to be the vector between them. And it's all there. But there's no good way for the GI person to say, summarize all the cardiology history for me, or for the cardiologist to say, summarize all the GI symptoms this patient's had. And so that is what we suffer with is like lots of information, not enough summarization.
Is it just overall this happening on a daily basis? Or is there a point where you said there's something fundamentally wrong? Like, is there one instance where you just thought, okay, this has to be done better?
Absolutely. So one example has always stuck with me. At one point, I requested in my primary care appointment that can we plot my weight over time? And I was counting, it took something like 28 clicks. Is it ridiculous? Like that is not the amount of clicking around a physician should have to do. And then if we zoom out a bit with all of these specialties, everybody writing documents, imagine a patient timeline. So for our listeners, you're going to use your own imagination, an add off time going left to right on which things happen to a human being, which is their lived experience for their health or medical condition. And then some of it is documented, depending on what specialty, written down in a document, a lab test, an imaging study, an EKG. We collect lots of information. So you can imagine these as tracks of information going along parallel to that timeline. And so the essence of the problem is how do I retrieve the relevant portion of the timeline that matter at this point in time? And right now we're pecking around. And then these things called large language models came around, which have been trained on the general internet, which is fine. You can pose a question or answer from the general internet, but I can't pose a question about my medical record because that medical record has not been seen by that language model. And so the problem sort of boils down to how do I package this entire timeline of the documented experience of somebody's health journey, feed it to a language model, and then create an interface that we can talk with it and we can ask questions and say, has the patient had a colonoscopy? What are the psychosocial barriers this individual might be facing? What did dermatology say about this lesion 3 years ago?
We've never had that before. We've never had this ability to go through that timeline and the accumulation of it. So let me follow up with two questions then. One, can you tell our audience, because I think that's something people don't really actually understand, that these large language models historically haven't been trained on this data, right? And a lot of it is being trained on internet data, at least the general ones. And then tell me how to make it better.
So think about it this way. Let's say we have a model that is trained on everything up to yesterday, which is typically called the knowledge cutoff. And it's usually not yesterday, it's a few months in the past. Now, if you ask a question about today's news article to that model, it can't truthfully answer. And so you might have seen that in all of these publicly available things like Gemini and GPT and so on, you can now put in a URL and say, summarize this article, which is a way of providing today's context to these language models. And so the answer you get back or the summary you get back is pertinent to the article you submitted and not something from a historical record. And so in that case, we're not using the language model as a repository of knowledge. We're using it as a processing engine to manipulate textual content and say, retrieve and summarize the right piece of information for me.
Hmm.
As a concrete example, like literally today, a cardiology fellow, frontline trenches of patient care, sent a note to our CIO saying, I'm deeply appreciative of the work that you have done to improve the efficiency of our day to day. This individual used to see 8 to 10 consults a day and now has to do 25. And it allows them to essentially summarize patient records on the fly, cut down on information gathering time from a few hours to a few minutes, allowing them to spend more time with the patient.
Okay, so tell me about this. Tell me about the work that you're doing.
So the word to remember is chat EHR. And just like you can chat with a news article in the New York Times and upload it to Gemini or Claude or whatever and say, summarize this in 3 bullet points. Imagine being able to do that with the patient's record before the patient even comes to you. And so when the person walks in, you've already read what the record says. Another example is an individual who was working in HemePath and were tasked with seeing somebody's record. And that particular patient, 6 pathologists had looked at the slide, 70 immunostains had been done, and there was a molecular signature of UV damage. And this person had a suspicion that maybe they've had some kind of other UV damage related medical thing happen. And by querying this longitudinal record in a few iterations, they figured out that there was an outside diagnosis of sarcomatoid squamous cell carcinoma, which explained the molecular findings. And which then allowed them to do a confirmatory testing. And a person who had bounced around 6 pathologists and 7 immunostains finally got a diagnosis.
Wow. Tell me then, as a clinician, how does this interface work? How do you actually interact with it? Is there something that you can show or like see and, you know, be able to interact with?
I'm sure we can pull up the image from the published paper. And the way to think of it is there's 2 core capabilities. Core capability 1 is retrieving the entire patient timeline, packing it in this standard called Fast Health Interoperability Resource or FHIR. And then, even if it's too big, like 20 million tokens, manage that big of a cognitive token load in querying language model. That's the technical piece. There's nothing to see there. It's all engineering Python code. What the user gets to see is a tab inside of their EHR system. That tab, when it opens, just like you're submitting a news article to a language model, has already submitted that patient's timeline to a language model, and it's in memory at that point. And then you literally just ask questions. And when we examine in an anonymous manner the logs of what are people asking, we find about 500 different kinds of things that physicians, nurses, residents, medical students are doing with the record. The topmost use case is summarization, essentially answering the question, how did we get to now? Like, catch me up.
I know we talked about it before, but how is that different than if people say, well, I could just go to ChatGPT or Gemini, I could go and just use that tool and do the same thing. Obviously, removing the HIPAA compliance and issue, but I could go and just kind of ask that. Why don't we just use that instead?
Well, has ChatGPT or Claude or Gemini for that matter, do they have access to the patient that is in front of you? It's basically trying to answer what happened in today's New York Times based on your knowledge cutoff as of 2 months ago. You will get something back, but guaranteed it's going to be weird. You can use it for querying literature and guidelines. So if you summarize the case and say, for patients like this, a 45-year-old male with high LDL and being prescribed a statin, what are the common side effects? Well, that you can get, but it can't answer the question, has Nigam Shah had a colonoscopy? Like, how would the internet know? And so there's two different kinds of retrieval that are happening. If it is generalized knowledge, as in things we believe are in textbooks of medicine, so to speak, that you can retrieve from general language models. But if the information is about a particular document, in this case, a document is one patient's record that could be 20 million tokens, the language models have no access to it. So you have to give it to them. And that's where the system comes in, putting the EHR and the chat capabilities together, hence chat EHR.
It's very personalized then, very specific towards the patient.
Correct.
And so, how do you see this helping patients? Like, how is it different? How do you feel both from the provider standpoint when you talk about it to patients? How is it going to help them?
The simplest way it helps them is that it bridges that information gap that the specialties have across each other. It actually does provide a comprehensive view of what is going on with a person. And that in and itself, like for example, when a radiologist is reading an image, if they read it just a cold start, you see the picture and nothing else, versus you see the picture and you have a one pager of what happened that led to the picture. That interpretation and the quality of the help they can provide, the quality of the read is much better. And so our vice chair of radiology here has Dr. Larson now requires all the 3,000 reads that are done every day to first have such a summary, and the radiologist should read that summary before reading the image. And so for patients, like direct translation, that your physician is now better informed about the context in which you're coming to them.
And how do we know that, like, this information is being kept private in that type of way? There's always those concerns with that.
Whatever is in an institution's EHR remains there. Even the language model that we're using for such retrieval and summarization runs in the same private cloud tenant where our EHR runs. So we're not sending this over the internet to a third party. You could with BAs and so on, but that's not what we're doing. We keep everything in our own sort of computational tenant on Azure. All the models are brought in. The patient record is in the same environment. And then we provide a visual interface for a physician, a nurse, or whoever to query them.
Is this system being used now? Do you see this expanding in a way that being able to, collect data from multiple institutions? And is there a point too where patients can bring in their own data, like for instance, like digital data or their, social media data or their Fitbit type of data into the mix?
Not yet, but I like where we're headed. Today, things that can be pulled through a health information exchange, such as Care Everywhere in case of Epic and others for other EHR providers, those can be pulled in to fill in the gaps in a patient's timeline. Scan PDFs can be pulled in a patient timeline. Messages that the patients have sent to their physician or their care team through My Health or My Chart, they can be pulled in. We don't have ability yet to upload documents by the patient, but that's just a technical and an execution barrier as opposed to a fundamental barrier of some sort. And you got to prioritize what you do first. The biggest value right now is there's this user interface, which 2,300 of our individuals are using, but there is this automation interface. So, for example, and this is where it benefits patients directly. Most institutions will have multiple care sites. There's a high acuity site, a low acuity site. The low acuity sites usually have, less drama going on, easier parking, closer to home. And there's a document somewhere that specifies which patients can go where. But in the busy ER, not everybody has the time to read those documents and say, Mr. John Smith can go here. A language model, always on, reading the medical record, reading those criteria, at admit time can say, this person could be admitted at this facility, which is, closer to their home. It improves the patient's care experience. It unburdens your highest acuity facilities. And in general, when you're at the right care level for your need, you get better care. Now, these are indirect effects for patients. So we have a patient and family advisory council, and we have had requests for patients to have a direct interface to this system. We don't have it yet, but that is where we're headed. Like eventually, we will have access to chat with our own medical record. Like we can already see our medical record, which a decade ago was like, why would you want to see your record? And so I think it's coming.
Well, that's fantastic because I think more and more, patients want to, and I'm hoping to, are getting more involved with their care and similar to like yourself, curious about can I see my history and can I see the timeline? So that seems like a next phase that will also be very beneficial. To kind of close it off in terms of your vision for this, I opened with the scenario of walk me through the moments where you found things were, fundamentally wrong. Now walk me through a scenario. What would you like to kind of see the system being able to do and how will that change the daily practice of a clinician?
Love that question. So back to our patient timeline, that arrow of time going from left to right, and then the different tracks of information underneath it, medications, the ICD codes, the notes, the imaging, the waveforms like EKGs, EEGs, and so on. We can keep adding, maybe 100 tracks of information. And then we have these 100 tracks sort of following time. And then each one sort of beeps when something gets recorded, right? I mean, we don't record everything every time. So it's pretty sparse in that way. You get an MRI and then you get one 5 years later. Like, we're not going to do it every day. You get a colonoscopy, hopefully it's a decade later. Like, I would not want my colonoscopy repeated every year. So we have this timeline structure, arrow of time, these tracks of information. And then on that, we need to execute certain computational operations. The most common one is summarize how we got to now, which is what we're doing today. Well, the immediate next one is what's the relevant literature for this particular situation? There's public APIs for that. After that, what are the guidelines? What does the latest research say about this individual? If that doesn't answer the question, what happened to similar patients? And we at Stanford have integrated the ability to pull in the evidence from similar patients in the pre-visit summary that is created for a physician before they see a patient. And so that's a company spun out from Stanford, Atropos Health, that does that. Once you get the similar patients, are there trials if that doesn't answer the question? Can we bring in active trials for this patient? Can we start forecasting what is going to happen to this individual? So each of these things, like, you start with what's in the record. And then you go step by step to a higher level of capability. What does the guidelines say? What do the literature say? What do the similar patients say? Are there trials? And eventually trying to make forecasts and prognosis of what could happen for this patient. And that's where we're headed.
I do really hope so. I'm always shocked at how little information that is used about the history of the patient or just even evidence-based records or comparisons with patients with similar health conditions are used in order to treat the patient or to diagnose a patient. I'm hoping that the system can fill those gaps.
I mean, you've heard me say this before. I think healthcare is the only industry where we don't learn from what we did for our prior customers.
I have not heard that, but that is very telling. That is very telling. And I don't think our listeners really actually all know that either, but it's shocking.
We talk about it, right? I mean, we talk about it. We have words like the learning health system. We've had efforts all the way going back to 1970 from Dr. Alvin Feinstein trying to summarize a resemblance set of patients, as they called it back then. I mean, the intuition is still the same. I have everything that I have documented about this individual. One, I need to be able to summarize it and think about it in my reasoning. But second, what happened to other similar people? Because that is very informative when you have an evidence gap in treating the particular individual. Whenever stuff like this happens, whenever people take matters into their own hands, so to speak, it means there is a gap that we're not fulfilling. And today, in my opinion, the biggest gap is what I would call this information gap. It manifests in two forms. Form number one is we have these complex medical record systems and nobody really knows what's in it. And then gap number two is that for a majority of clinical situations, we don't really have published evidence. And those two gaps, the information gap and the evidence gap, are the kinds of things that tools like Chat EHR attempt to bridge by first summarizing what's in the information you already have in your systems. And then, second, pulling in evidence from outside sources, from the literature, from the guidelines, from similar patients, and so on.
Well, thank you, Nigam. Thank you for explaining all of this really complex information and for trying to help the system be better. Thank you so much for being here.
Absolutely. This allows me to see a million patients a day instead of seeing 5 or 10.
I am Dr. Yulin Hswen, and I've been speaking with Dr. Nigam Shah about building systems that let doctors chat directly to patient medical records. You can find a link to this article in the episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.